Welcome to At Home Rehab's Physical Therapy Visit Note Training. Before watching this video, you should have already reviewed the printed basic guidance and the sample visit note with examples. Jennifer is going to review how the clinician who opens the case or who enters the first note enters information that will carry over to all future notes. Then she's going to go over how the notes will be completed at each of your visits. I'm now going to turn over to Jennifer, who's going to go right into the note.
If you have not already read over the general guidance and the example note with samples, please stop this recording, do that, and continue the recording when you are finished. It will really help you guide through this much more easily. The first thing I want to mention is in the past with the old notes, the note was part of the OASIS assessment. It is going to be different moving forward. It will not be part of the OASIS assessment. The note will be separate. The reason for that is so that for a few reasons. It can flow through from note to note, the information, and it will be the same note for each one. It will be the evaluation, the visit note, and the reassessment. The reassessment will have a separate note with it. So when the PT, for example, does their OASIS assessment, their start of care, there will not be clinical information on it. That will be an administrative form, and the billable form will be this note, which they will fill out, and it will carry sections of it will carry to the plan of care. This will allow, since notes have to be done by midnight of the same day, it will allow for the PTA or the PT on their next visit to see exactly the history of present illness and other things contained in the note and not have to wait until the OASIS is complete to see that information and to carry it through for consistency. So the first section is history of present illness. The history of present illness will be filled out by the PT on the evaluation visit and will carry through from note to note. So every clinician will be able to see the history of present illness on all their notes and refer to it. My suggestion is to list your diagnoses first so everybody can have a quick view of those, and then to tell the story of what happened to the patient. For example, start with how they were prior to their change in their functional or medical status, whatever that change was that caused them to need our skilled services. Then after you outline that, talk about what happened to the patient. And then after you discuss what happened to them that caused this change, why they need our services, and what we are going to do to help them get back to their prior status or their maximum potential, considering what their diagnoses were and their medical limitations. I provided some examples in the note for you. The next section for frequency and duration, you're going to list the exact frequency and duration of your patient's care. And of course, use your professional judgment to specify what you think on that day they will need. Of course, nobody's a predictor 100%, but you need to write what you think they're going to need when you're evaluating them. Avoid wide ranges like 1 to 3. If you're going to use a range and you use a range of 1 to 2 or 2 to 3, then you need to start at the highest part of that range. For example, if they're 2 to 3, you need to start at 3 times and then reduce to 2 over the period that you say that they're going to be in that range. So I provided some examples, and for an episode is about 10 weeks. So if you do plan on seeing them through that entire episode, then write your orders to cover that episode for 10 weeks. In homebound reason, as you see, it's the same statements as we had on the past notes, except I would really like you to write in the other section so that some of these other wording, it could apply to any patient. So what we want to think about is our specific patient, not just any patient. Dependent on his adaptive device, majority of our patients are dependent on an adaptive device. What makes this patient different? So under other, you're going to check that off and you're going to write exactly what makes this patient different. Why are they homebound? Maybe they're homebound because they require a moderate assistance to sit to the edge of the bed for 30 seconds due to weakness from a spinal cord injury. That would definitely make them homebound. So something that you can think of about this specific patient that could not be argued by someone, and it is objective. So for vital signs, pretty straightforward. I recommend pre and post TE vitals if there is any concern with for protection of the patient and for protection of your medical license. As professionals, you should know when you have some concern and you want to document a vital sign after they do exercises. One thing you do not want to record, actually two things, is the pulse ox or the blood sugars, unless the patient took them with their own machine. Right now, we do not have liability to be using our machines to document those readings. In the order section, you want to specify exactly what you're going to do with this patient. One example might be therapeutic exercise, but if you're going to do therapeutic exercise, you might want to specify whether you're using weights or not, resistance, um, neuromuscular reeducation and what you're doing for that. So you want to be specific, because if you are not specific about using weights and someone gets hurt and that's not on our orders, that could be a problem in the future. If you do write a physician order, if you do change your orders on here, you would need to write a separate physician order. So, for example, on the first day on evaluation, these orders are going to carry right into the plan of care. So your frequency and duration on the pass box I talked about, say it's 3 times a week times 10 weeks, that's going to carry into your plan of care and your orders. So when you write those on your first visit, you don't need to write a separate physician order because that's going to be part of the plan of care. When you change your orders on any future visit, you can change them in your note, but you also need to write a separate physician order changing these orders. So in the subjective section, you want to make it patient specific, related to your goals, your care plan, your limitations. It should tie together with the entire story. So for example, you don't want to write, if they make a lot of statements during that visit, you don't want to write a statement that has nothing to do with what you're doing with that patient. You want to pick the statement that has something to do with how they're progressing or their limitations. Under the exercise program, if you're doing the Otago program, the knee surgery protocol, or the hip surgery protocol, please just write in this section, see page 3, 4, or 5, whatever page that program you're doing is on, and I'll review that in a second. You want to avoid in your exercise program writing vague statements like performed hip exercises or continue with home exercises. You want to specify the frequency, intensity, time, and type. And please refer to the examples on the handout. There's some good examples demonstrating how when an auditor is reading this, you want them to see exactly what was done in that session and not just a blanket statement. Under the section New Education Instruction, you want to detail any instruction that was given to the patient, the caregiver, the paid caregiver during that session. So if you do review something in the admission workbook, which we highly encourage under the prevention of rehospitalization section, we've outlined a lot of education for the patient. You can refer to that topic and you can say reviewed prevention of prevention of pressure ulcers in the admission workbook. And then you can go ahead and initial that page in the workbook. You don't have to write specifics because that is part of what we give the patients and that someone could refer to that. In the notable progress section, you want to note what objectively they have progressed in. So you don't want to use statements like tolerated well or progressing as expected. Actually, you want to keep those off of your note completely. You want to be specific and objective. Goals, incorporate your special tests and the scores, any setbacks or limitations, whether they be cognitive, environmental, financial, lack of support, etc. You want to consider the whole person, not just their knee joint or their hip joint. The entire person, their environment, and their support systems, as well as their cognitive, should be considered in this. If you are not noting progress with this patient, this is the section where you need to put what are the barriers, what's preventing them progressing. That's very important. And the justification of your future care. Under plan and discharge planning, if you know the date of the next visit, please state it here. And also state specifically what you're going to work on for the next visit. It doesn't have to be everything, but if you're going to work on something new, maybe note that you're going to attempt stair climbing with the patient or initiate car transfers, initiate Florida chair transfers, whatever it is that you're going to initiate in the next visit or work on further with that patient should be noted in this section. If you don't know the exact date you'll be returning, specify, will return in 2 to 3 days, something to that effect. Under the discharge and care communication section, discharge would be anything that you reviewed as you get closer to discharge. care communication is any detail of anyone you've spoken to during the visit. Make sure you put the details of the conversation to protect yourself. The next section is the chart, and this is new. This is going to look new to everybody. And the purpose of this chart is to see a bird's eye view of the patient on one form so that anybody can pull up a single note and see across the form what the patient's prior status was. Prior status is defined as what their status was before the change in their functional or medical status. Basically, before the change occurred, and the change is the reason that we are in there seeing them for our interventions. The status on evaluation would be their status at the time of your evaluation and considering the 24 hours prior to that. So if you're there at 8 a.m. and at 8 p.m. the night before, that patient was completely dependent in transfers, then they would be dependent on your evaluation because you have to consider the 24 hours before you're evaluating them. Current status can be left blank on your evaluation note and filled in on future notes. On the future notes, you would be filling in only the current status on this chart, and all of the other sections would carry through. Short-term goals and long-term goals are going to populate to your plan of care from your first visit note. After that, you can make changes to the short-term goals and long-term goals, but you may want to make a note in your narrative section that you have made a change to those, and they will carry forward onto the future notes. If a goal is achieved during your care plan, you can actually write in the front of the goal, so it can be seen clearly by everyone, the words "goal met," so that everyone knows moving forward that goal was met. If you would like to increase the goal, instead of writing "goal met," you can just change the goal to a further goal and then write it in your narrative. If you notice, there are short-term and long-term goals on these notes now. It is now a requirement to have short-term goals and long-term goals. By convention, I'll usually write my long-term goals for what I want the patient to be and look like at discharge. For short-term goals, you can either divide it in half by the date, or you could write 2 weeks out from evaluation, however you feel comfortable. But basically, try to think about your long-term goals first and how you would like them to look on discharge, and then write the short-term respectively by a shorter time span. If you notice on the chart, in the first 3 columns, it is okay to just write the word min or supervision or mod. And also, I would like you to add some more detail to that, and we're just doing this for the purposes of example, but you can even write min assist with 50% verbal cues or mod assist with 25% verbal cues. You can write some more detail. That's why I chose not to do drop-down boxes on these so that there can be specific detail. And those you can write just a word or two. On the goals, you need to write the whole sentence out. So, for example, patient will be independent with ambulation in order to make it to their bathroom at night. However you want to write your goal, but that goal is going to populate to the plan of care. So if you just write min, it's just going to put min on the plan of care and no one's going to know what that means. So please pay attention to that. The next section of the note is the narrative section. And in this section, you just want to detail anything else that occurred during the visit that is not included on the rest of your note. And remember, you are liable for everything you write on your note, so make sure that you're being clear and detailed with your notes. And not getting lazy. I have made these carry over from note to note. So do not get lazy about changing things. You need to constantly keep that current column updated, change your narrative section, modify your goals as necessary. The software company, if it can change these to not being populated over if I feel that people are getting lazy, and it's all or nothing. So if a field is populating now and I feel people are getting lazy with it, we can not make it populate. Also, the blank line at the end of the chart that you see, that gives you the ability to add in any special test or anything that you want to measure. If you notice the 5 times sits to stand at the end, I actually added that. That wasn't part of the note. I added that in, and I believe the driving part I added in too because they're in bold. So there was left a third blank that I did not fill in. Your therapy reassessment addendum is going to be a little different than it was before. The other way was that it was attached to your note. It was attached on the third page. It's no longer going to be attached. I wanted to make this easier for everyone. One, so the office could track it easily, and two, so that if you forgot to do it, you can just go back and add this extra addendum without having to redo the rest of your note. So the addendum is pretty straightforward. You have to basically document goals added, modified, terminated, and met, and the reason since your last evaluation or your last reassessment. So anything that you've modified since then, you need to list those goals out, not just C note or a general comment. It has to be actually listed out because when someone picks up this form, you want them to read a story about the patient. This is why I added the following goals. Objective reasons related to their care plan. This is why I modified the goals. Something changed in the patient's life. This is why I terminated. And you want to note that there's a realistic expectation that the patient's going to reach the goals that you're setting. Then you want to use the rationale for continued treatment, if you're continuing, as a good narrative so that it will substantiate your care. That there is a reasonable expectation that they'll reach the goals based on past progress. No canned phrases. It must be objective. It must relate to your goals. If there are any setbacks, you want to note those. Say, for example, they had a recent fall. You want to note any and all barriers to their care regarding cognitive, physical, environmental, and support systems. In the next section, you want to indicate any reason for slow progress or inconsistent progress. And you also want to state your plans and your rationale for continuing. So you want to state in the plans exactly what you plan to do with the patient. Frequency, duration, and plans. If you are not Otago certified or you're not a member of the specialized joint team, you can end the video now. You are complete. I hope it was helpful. If you are interested in Otago certification or joint team membership, please reach out to Jennifer. For those of you who are certified in the Otago program, I have made a handy note here that outlines the exercises, the strengthening, the balance that goes along with this program. And you will be able to document on these pages, page 3, exactly what you did with that patient, the reps, and how they're progressing. So what you're going to do is fill this page in, and then under your exercise program on your regular note, you can just write see page 3. You can also write your goals based on the Otago program, so you can actually refer to different levels. For example, here under the balance section, A, B, C, or D, you can actually write a goal that says patient will achieve level C in their Balance Otago program. So it's great because it allows you for objective measures and a program that is based in studies and certifications. And on the end there, you have your test results and things there, so you can base it on your scores and you can repeat them so that you can show progress with your patients. Pages 4 and 5 are for the people that are on the specialized joint team, and this is an outline of the protocols given to us, and here you can fill them in pretty easily, and you can change your reps as you go along to show progress with the patient. And on the bottom of each of these forms, I have outlined some of the things that we're supposed to be doing as a member of the joint team, the home safety checklist, the shower transfers, etc., and reminders for doing the report card and uploading it to Devero. So I tried to make this as simple as possible to follow through so that we're making sure we're hitting all of the parts of the protocol that we need to be hitting when we're a joint team certified member. That concludes my review of the physical therapy note. Thank you for your time.